Welcome, everyone. I'm Dr. Shannon Dowler. I'm with the Office of Infectious Disease and HIV/AIDS Policy, and I want to thank you for participating today in the 5th of our summer series webinars. I know it might feel like summer's coming to a close, August is ending, kids are heading back to school, those school buses are slowing down your commute, but fall doesn't technically start until September 22nd, and here at OIDP, we are still summering, and with our webinar today, and again with our final webinar on September 10th. If at any time you need technical assistance, please contact the meeting host or panelist. Over the course of the webinar, please feel free to submit your questions and answers in the question and answer box at the bottom of your screen. We'll actually address them as the webinar goes on, but we'll also come back to them at the end, and we'll just continue to answer questions as they come in throughout the webinar. I want to thank you all for joining us today and your commitment to stopping syphilis in your communities. I am joined today by colleagues from the Indian Health Service and the National Association of County and City Health Officials and the Raven Collective. Together, we'll be exploring the unique challenges and innovative solutions addressing the inequitable impact of syphilis and congenital syphilis on American Indian and Alaska Native communities. Recognizing that effective interventions must be community-driven, this session is going to present key findings from the Regional Syphilis Partnership Summits, emphasizing the importance of collaborative efforts between state and local health departments and tribal communities, and highlight the work of the Indian Country Congenital Syphilis Taskforce. It was an initiative designed to align with federal efforts while focusing on the specific needs of the American Indian and Alaska Native communities. Before I turn it over to Rick Haberkate, who is branch chief of the HIV/HCV STI branch at the Indian Health Service, to provide opening remarks for today's webinar. In keeping with our established tradition, I'm going to kick it off with what is probably becoming a familiar audience response question. We've been using these audience response questions throughout our webinar series to help engage you as adult learners and to learn from you at the same time. So our first question, and if you've been to our webinars before, hopefully you're going to figure this one out really quickly. True or false, there is broad availability of benzathine penicillin 2.4 million unit doses, so we can now move away from doxycycline as the treatment in non-pregnant persons. True or false? Damon, let's see what folks have to say about that. All right, every webinar, it gets better and better. It is true. So really exciting news out there for folks who have had trouble accessing bicillin over the past year. It is now available. There's also extensilin and lenticillin. So we are able to shift away from that doxycycline treatment. The CDC is monitoring it. So if you are having trouble accessing bicillin 2.4 million units, they want to hear about it. So we're going to put an email address in the chat, and we want you to reach out to them. And we'll also have that email address again at the end of the deck. So with that, I'm going to turn it over to Rick.
Hey, thanks, Shannon. I really appreciate that question. We've been trying so hard to get past some of that misinformation about the availability of bicillin. So great. I'm so glad people are responding to that, those efforts. So I'm the branch chief at IHS for the STI, HCV, and syphilis. What am I? HIV, FC, and STI branch. It's a tongue twister. But I want to really welcome you to this session as we work to develop our partners and our coalition-based efforts to address syphilis among American Indian and Alaska Native communities. We know that these communities are disproportionately impacted by syphilis and the related syndemics of HIV and hepatitis C, but we also know that they cannot address syphilis without partners. So Jessica and Rebecca will share work from the past year that has been taking that approach of really bringing together tribal representatives, tribal health departments, Indian health boards, IHS, local and state health departments, and our federal partners to approach solutions in partnership. And I really want to say, if you haven't heard me say it 100 times, I'll say it 100 more, that I appreciate so much the investment that the Office of Infectious Disease and HIV/AIDS Policy puts in the IHS. And then, of course, that trickles down to our tribal and urban partners around the country. The work we do, 100% of the work we do has been funded through our trusted partners at OIDP. And I really thank you for allowing IHS to share in some of those resources and get them out of the Indian country to make partnerships like this possible. I'm going to briefly introduce the next two presenters. Rebecca is the director of STI programs at NACCHO, the National Association of County and City Health Officials, which represents more than 3,000 local health departments across the U.S. And Jessica Leston is owner and partner in the Raven Collective and has over 20 years of experience working in sexual health in Indian country. I look forward to hearing from Rebecca and Jessica and fielding questions and comments from the audience and to help build partnerships that take action on some of the innovative solutions developed as part of this work. So I'm going to turn it over to Rebecca now.
Thank you, Rick. Hopefully you all can't hear my dog, who apparently wanted to participate in the webinar. So we're going to start out with a couple of poll questions. Damon, do you want to bring up the first one? So the first question is, where do you currently work? And we can pull up the answers. Really good mix of federal, state, and local. Really glad that folks are here from all levels of this work, as well as our others. And then for the second polling question, for people who do not work in the Indian health system, how often do you work with American Indian, Alaska Native communities or organizations? And we can pull up the answers. Awesome. Really good to see a bunch of nevers, because hopefully this work will speak to you as we go through and share some stuff with you. And then the last one for right now. Damon, the last. Thank you. So what is the rate of congenital syphilis in American Indian Alaska Native people? And we can see the answers. I'm glad to see that a lot of people do know the rate, but I'm also wondering if people guessed the highest number because they know that this webinar is happening. But thank you everyone for doing those polls. So we can go to the, I can control it. Yes. So this webinar is about insights from the Regional Syphilis Partnerships Summits and the Indian Country Congenital Syphilis Taskforce, as well as both Shannon and Rick have shared. I'm going to give just a bit of context. Damon, if you could just go to next slide. I'm not going to be able to control multiple things. Thank you. So our agenda today is talking about a little bit about the need, the context, and then Jess, I'll hand it over to Jess and she'll talk about the work that we did in the last year. So I'm just going to give a little bit of context. If you can go to the next slide. So everyone knows this information. This line continued to go up across the board in 2022. Unfortunately, next slide. So this map shows at the state level the significant increases in maternal syphilis from 2016-17 to 2021-22, and that almost all jurisdictions had an increase, including 6 that increased by 400% or more. Next slide. So NACCHO is the membership organization of local health departments, and those local health departments are tasked with addressing syphilis in their communities and counties. So if you zoom in from the state level map and go to the county level where NACCHO members work, it's clear that certain counties are the highest burden, the highest priority. And that's in both states that have a quote high syphilis rate, as well as states that have a low one. So as a result, it was obvious that efforts to address the rising rates of syphilis must occur at the county level. Next slide. So as we were thinking about that and the efforts that local health departments needed to have to address syphilis, we also started to look at additional context. So in addition to taking that step into the map to look at overall rates and look at them at the county level, you also have to look at the impact of syphilis on specific communities. So here you can see that the burden hits hardest on American Indian Alaska Native communities who are seeing significantly higher rates of syphilis than other racial and ethnic populations. Next slide. Surprising no one, same numbers, again, for congenital syphilis, as those numbers generally align. And then you can go to the next slide. So this is the same map that I showed on slide 5, but with the location of some of the largest American Indian Alaska Native communities circled on the map. And as you can see, some of the densest areas of syphilis burden are within those circles in many states. So the counties that are trying to address syphilis based on this map, because of the high numbers, are also counties where there is a large American Indian Alaska Native community. And so this demonstrated to NACCHO, to me, that if local and state health departments are to adequately address syphilis in their communities, they're going to need to, one, work with tribal health departments, tribal councils, IHS, and two, recognize that American Indian Alaska Natives do not only receive care, especially STI testing, on a reservation or in an IHS facility, and that partnership must occur to confirm testing and treatment across providers and health departments serving these communities. And obviously, this is especially important when it comes to women to bring down rates of maternal syphilis and subsequently congenital syphilis. So this really showed us that without coordination with American Indian Alaska Native communities and the providers that serve them, there was really no possibility of bringing down rates in these counties. Obviously, NACCHO's goal in supporting this work is in recognition of that need for the partnership and coordination. So we're going to do one more poll. Folks can vote. Where do most American Indian Alaska Natives receive healthcare services? And you can show the results. Awesome. Yeah, it's whatever community they live in. They may go to an IHS facility, they may go to an urban Indian healthcare facility, they may go to a hospital, the urgent care, a health department, but they are entitled to receive services wherever they are. And so that's really another reason why this work was so important to NACCHO and important to me. So I'm going to turn it over to Jessica to talk more about the work that we've been doing in the last year.
Thanks, Rebecca. So in this slide, we see what I think is one of the most important issues with congenital syphilis in the United States right now. And that is the immense inequality seen in cases of congenital syphilis per live births in whites compared to American Indian and Alaska Native individuals. This isn't to scale. I sort of quickly threw this together as an example of just like how disparate the rates are. This slide shows national numbers compared to numbers in South Dakota. A white baby born today in South Dakota has a 1 in 3,988 chance of being born with congenital syphilis. A Native baby born today in South Dakota has a 1 in 42 chance of being born with congenital syphilis. This shows that not only within the country, but within states, within local health jurisdictions, there are dramatic differences in health that are closely linked to degrees of social disadvantage with various racial and ethnic groups. And differences of this magnitude simply should never happen, no matter what we're talking about, no matter where in the world, they should never happen. Tribal leaders, tribal health directors, public health professionals, advocates, and allies in this work have communicated the need for systemic changes to achieve health equity. And these inequities in health, avoidable health inequities, arise because of the circumstances of not just the spirochete, not just syphilis, but because of circumstances of where people grow, where people live, work, age, and the systems that are put into place to deal with illness. And that is really what we're talking about when we're talking about the huge inequities in syphilis in the United States right now. Next slide, please. I'm sharing this model of social determinants of health as a precursor to the work that we have done over the past 8 months. In a recap of this work, you will not find much mention of screening for syphilis 3 times in pregnancy, nor will you find the use of reverse algorithm or rapid tests. Although we know that this too is really important, those technical things. Overwhelmingly in our conversations in both the Regional Syphilis Summits and the Congenital Syphilis Taskforce that was guided by community and people on the ground, was speaking to broader causal factors, those factors of social determinants of health inequity. And the conversations that we had centered people and communities being at the very center of this outbreak, and the very center to the response. And this includes not only people that are working within the health systems, at local health jurisdictions, at the states, at IHS tribal and urban facilities, but also the people that actually have syphilis and understanding everything that they are going through in their life and in their infection, so that we can actually attend to that and put a stop to that. Next slide, please. So in the spring of 2024, the Raven Collective, in collaboration with NACCHO and Cardia, convened 3 regional syphilis partnership summits. Attendees were from the Indian Health Service, tribal and urban clinics, regional tribal health boards, tribal epidemiology centers, state, local, and tribal health departments, academic institutions, private hospital networks, probably more places that I can't name right now. The Indian Health Service's HIV, hepatitis C, and STI programs was really involved in the planning and facilitation of each of the summits. And they took place in the Southwest in March. That included the people in the states of Arizona and New Mexico. The Northern Tier Summit took place in April, and that included people from Minnesota, Montana, North Dakota, and South Dakota, and the Southern Plains in May. And that included participants from Kansas, Nebraska, Iowa, and Oklahoma. There were more than 60 attendees at the Southwest and Northern Tier Summits, and over 50 attendees at the Plains Summit. And the purpose of these regional syphilis partnership summits was really to work together to close the systemic gaps in syphilis response in American Indian communities in each of the regions, including by using a very systems-based approach. And while each region and the communities and the tribes, the states were different, all agreed that the work to address syphilis must be supported by federal partners, but envisioned and developed and enacted at the local levels. And across the 3 regions, similar stories emerged, and we'll go into those stories, those findings in the next couple slides. So next slide. Communication and partnership was by foremost one of the key things that came out of the summits. It was noted that successful syphilis response in Indian country is going to depend upon thoughtful and ongoing communication and active partnership between the tribes, the Indian Health Service, and everybody else involved in a syphilis response that could touch a person with syphilis, that was dependent upon this system that surrounded it. And building and strengthening collaboration with partners was really important. And oftentimes, especially now, there is not enough programming, funding, and attention that actually is being delivered to just developing these partnerships. Not really attached to any other huge outcome, but the partnerships and the relationships themselves are just so important to nurture and to grow. So next slide. The next finding was similar in collaboration and partnership, but spoke to the critical need to strengthen collaboration with people outside of sexual health, with people outside of STD. For example, maternal child health programs, behavioral health programs, shelters, youth serving organizations. Because if you put the person at the center of the response, then we know that people with syphilis have all of these other needs, especially a pregnant person that needs coordinated and managed care, especially in a lot of these places that we're talking about that are very rural and don't have access to maternal child health and prenatal appointments. for behavioral health programs, for substance use disorder treatment, also so tightly linked to the current syphilis outbreaks that we see happening in Indian country. Next slide. One of the other findings was that high levels of stigma are impacting prevention, screening, treatment efforts, and everything surrounding syphilis. And stigma impacting syphilis includes sex and sexuality, being able to discuss when, why, where, and how, and with who people are having sex, and who with. Substance use disorders in pregnancy, and houselessness. And that policy changes are needed at all levels in order to address the stigmatizing structures such as law and regulations in these areas. And you'll hear some of these things being repeated in the congenital syphilis findings as well. Next slide. Another finding was that community education should be strengths-based and sex-positive, building on Indigenous values and concepts of health and wellness. And this happens to varying degrees across different organizations and across time, especially like looking at the politics of the US at the time, but that this is so critically needed in order to start young with age-appropriate sexual health education and everything that is attached to that. Next slide. So the first note of testing was that syphilis testing must be offered in both clinical and community sites to meet people where they're at, to address stigma, and to promote access to testing and treatment. Syphilis testing should be implemented using a syndemic approach as well. That includes not only syphilis testing, but other STI testing, hepatitis testing, HIV testing, harm reduction when appropriate, and really supportive wraparound services. Again, putting the person at the center of the response that's being developed. Next slide, please. This is another finding that is going to be repeated in the Congenital Syphilis Taskforce, and that is an increase in the public health workforce is very needed, particularly for contact tracing and care coordination at the tribal level where people are, and in communication with the state and the local health systems. Hopefully leveraging the various different community health workers that the Indian health system has, the community health representatives, community health aides and practitioners, health techs, public health aides, and traditional practitioners, using whatever the community has, very similar to the response as seen in COVID, and how successful that response was using local-based people to do contact tracing. Next slide, please. We also found that that IHS tribal and urban clinics, tribal health departments, regional health boards, tribal epidemiology center must have access to better data in order to respond to syphilis. And this is going to look different depending on the local situation, the outcomes that the tribe, health board, etc., wants to have. This data sharing will look different, but the important thing is to build trust so that more information is flowing at all levels, and to everyone who is trying to respond. And so those findings sum up those from the regional syphilis summits. Rebecca, I just wanted to open it up to you to see if you had any other comments to add in before moving to the poll and then the congenital syphilis task force themes.
I think the only thing that I would add is the impact that this had for local health departments. These are not things that they didn't know, but it was acknowledging the things that are hard for them are hard for the American Indian communities and hard for the tribal health departments and hard for IHS. you can't confirm that someone was treated if they're traveling between locations without having strong communication, without having strong partners. And that might be between two STI programs, but it might be between a primary care physician and an STI program. And only with the data systems that speak to each other will you be able to confirm that information without having a person-to-person call, which is not a reasonable expectation for long-term, for addressing a system long-term or an issue long-term. So I think having everyone in the same room talking about these concerns and recognizing that the concerns came from both sides and they were the same was just really insightful for everyone and really grew those partnerships and the desire to partner. So that's it.
Yeah, no, I think that that's really important. And please, if you have any questions, please feel free to put them in the chat. I'm sort of looking at them too. But I mean, I think it is really important that like these findings aren't coming only from the Native community. These findings were from everybody that participated at these summits. And it was really, these findings were created in partnership and in unison with everybody that was there. And so I think that that is really important. And I think you touched on something else that was sort of brought up earlier, but you know, the issue, the increases in syphilis, the outbreak of syphilis is no more an Indian Health Service problem than it is the person's problem that has a positive syphilis test. It's the systems problem. It is the infrastructure, the constructs that we have in place. And so it's also those constructs in that system that's going to be responsible for helping to address the outbreak. And in any kind of systems thinking, it's not just like putting bubbles on a map and saying this is the system. The strength of the system is derived from the connections all of those bubbles, people, organization have with one another. And I think that that this summit series was a really good first step in coming up with the possible solutions and better developing those relationships and partnerships too. Okay, so I think we have a poll question now as well. Okay. So what were some of the key takeaways from the Regional Syphilis Partnership Summits? And all of the options are below. And Rebecca, I don't know if you want to help. There was a question that popped up as well. Do you want to wait? Do you want to answer this now, or do you want to wait to the end?
I'll answer it in the Q&A.
Great. Okay, great. And we can talk about it at the end too. Okay, we can close the poll. Correct. We threw you a couple of bones. This was easy. It was easy to answer all of the above and more. So thank you. We can go ahead and move on to the Congenital Syphilis Task Force work. So a similar timeline to the regional partnership summits. The Raven Collective, in partnership with Cardia and with the support and funding from NACCHO, convened the Indian Country Congenital Syphilis Task Force in January of 2024. The goal of the task force was really to explore the current system, the obstacles, the resiliencies, and the stories to develop the strategies that are needed to address the needs and concerns of congenital syphilis in Indian country. So the task force had meetings starting in February and then went all the way through June/July, early July, and was divided up into two different groups. There was a regional subject matter expert group, and that consisted of 23 tribal, regional health board, and local public health organization representatives from all of the IHS service areas or all of the HHS regions. And then a national subject matter expert group consisting of folks from the Indian Health Service, CDC, NACCHO, and other organizations. And it was really purposefully structured that way with regional SME and national SME to center the knowledge and the wisdom of the tribal, regional health board, and local public health organizations, and to support the storytelling between those partners to address the epidemic on multiple levels. So we will go into the themes for the next couple of slides. So the first theme, I think that you're a slide ahead of me. I haven't talked yet, thank you. The first theme really centered around cooperation and partnership, also a theme from the Regional Syphilis Summits. And those really were to center partnerships across programs, which you mentioned before, maternal child health, STI, substance use disorder, etc., and organizations, whether it's IHS, tribal, urban, state, local health department, private hospitals, delivery hospitals, which is really important, which is a really important component when having conversations around congenital syphilis. We really heard over and over again to prioritize maternal child health and the delivery hospitals that are most likely not part of the Indian health system, and other places where pregnant people and families go. For instance, in WIC programs or Head Start programs, etc. Giving education and communication and having conversations in those spaces. So, and again, I don't think that I can stress enough how important the overlap with substance use disorder and treatment programs were in both the congenital syphilis and the Regional Syphilis Partnership Summit findings. So a huge gap to be sort of lessened in that space. Next slide. The other theme was around building the care framework. And what we mean by that is, putting the person at the center again, and really making it be about how can we better build this blanket around you, whoever you are, in order to make sure that you have access to the best health and wellness possible. It was also brought up that this framework should use holistic and syndemic health approaches. So not only to promote syphilis awareness and screening, but also awareness around a whole other host of health issues, mental, behavioral, spiritual, and physical health. Also to offer connection and patient-first care at every single encounter. And I know that we talk about this a lot, and I know that there are a lot of there's a lot of pressure being put within for clinicians and health systems to make 20-minute appointments, to make sure that they're making enough revenue. But the need to make sure that no matter where a person is entering the system, whether it's in the ER, whether it's at primary care, whether it's the optometrist or pharmacy, that we're thinking about this care framework, and we're touching this person for whatever the reason, and all of these different spaces. And really that's just around meeting people where they are. And whether it's at within the health system itself or not. Also in this space was implementing universal testing for syphilis wherever people are. I know Cherokee Nation has a really good example of what they're doing in this, and they have started screening everybody for syphilis that enters their health system, no matter what, and it's just routine, and the blood is drawn for everyone. And then lastly, to provide support to help engage patients who would not otherwise be able to make or keep appointments. And this speaks again to that case management, care coordination for people. And I think this is really important because, like, when we're looking at the social determinants of health and equity, and when we're looking at all of these social constructs that are put into place, for a very long time in this country, there have been multiple different events that have made it so that it is more difficult for certain people in the population to achieve health. And really what needs to happen, if you're taking a social determinants of health and equity standpoint is to give some people more in order then for them to achieve health. Give them more calls, pick them up where they're at, go to where they are in order to better engage them in the health system. Next slide. Another theme that came up was around nurturing the Indigenous workforce, and to really recognize the importance of the Native workforce. And I think this is really meaningful because we see over and over again within the Indian health system, and I think probably in a lot of other rural areas, that people come and they go out of the system. No fault of their own. They're coming to pay off student loans. They're coming because they want to make a difference, but it's really hard to sometimes stay in these rural and remote spaces. But if you nurture and recognize the importance and lift up the Native workforce, the people who are already in those spaces, who understand what rural and reservation life is, who want to do good for their community, if we make more opportunities for these people, then we could have a more robust, consistent, and stable workforce in these spaces, whether they're reservation or just rural. One of the quotes that we had in this space was, "I would love for this work to help promote Indigenous doulas and Indigenous birth workers." They also talked about the need to provide in-person opportunities to connect for the Indigenous workforce so that the Indigenous workforce can learn from each other, so that they could get capacity building and technical assistance, and then also provide that to the broader Indigenous workforce. And then coinciding with that is something that someone said that was really struck me, is that we need a way for them to be employed. We need a way not only to have an Indigenous birth worker or to have a community health representative, but a way for them to be integrated in a very real and tangible way into the existing health systems that they're operating in. And I think that there's a lot of room for improvement and growth in this space. And then lastly, there was a lot of conversation around contact tracing and how there isn't a contact tracing infrastructure really in most places in the Indian health system, which makes sense. You know, the CDC gives most DIS money to the states, who give that money to the local health jurisdictions. And so that is where the funding for DIS lives. But there's a lot of unmet need in the tribal space as well around contact tracing, because like simply a lot of the times the contact tracing, the DIS work doesn't happen if there's too much distance, if the person doesn't know community. So some of the quotes around this was, "I would love to see some support for this. We need to have community health workers we can train to work closely with the PHNs to do contact tracing." This has been a big hold because no one really holds the pieces of this together. And I would love to see support for this contact tracing. It's all about boots on the ground. We need further funding and program work within the Indian health system itself. Next slide. Is another repeated theme from the Regional Syphilis Summits, and that is, we need data for us. We need data for us on multiple different levels. We want to share examples of the good work that's happening in Indian country, because there are so many good programs, good people doing good work within the syphilis response in Indian country. And there's just simply not a good way in order to share that. Another question that came out was, do we have data that we need? Do we have the data that we need to make decisions about American Indian Alaska Native people? Our CDC and state reported data shared, because it happens in various different ways and levels depending on the state. And is what's being shared good enough to actually respond to syphilis? Which a lot of people in Indian country have been calling for a public health emergency for, you know, like if we think that syphilis response is important enough, is the data that we have to share good enough in order to actually respond? And then again, we need to better understand how, when, where, why people are having sex, how people are getting syphilis in order to build appropriate responses. Next slide. So we also had a theme around Indigenous ways of knowing and tribal best practice. This idea that we are all part of 7 generations. Case of congenital syphilis, their parent, their grandparents. We need to take care of health across a continuum. We need to create trust and understanding, and we can do that by really centering the voice of community members to foster the trust. Because we need community members and we need people with syphilis to tell us the best way to develop a response. And with NACCHO funding this scope of work, I think it's a really good first step of asking people on the ground who are doing the work what needs to be done, not only within the tribal health system, but within local health jurisdictions, states, etc. And affirm the Indigenous value of community health and wellness, and the Aluptic cultural value, we are responsible for each other and ourselves, while respecting tribal sovereignty and creating health priorities. All of this is really important to develop a on the ground response. Think global, but have to act local. And in order to think global, we need to understand everybody's experience in responding to syphilis. Next slide. Just 2 more themes from the Congenital Syphilis Taskforce. Oh, I'm sorry, next slide. Oh, sorry, one more slide before, the one with the plateau. Yeah, sorry, my bad. The idea that everything is connected, again, a recurring theme, but the intersection of congenital syphilis and substance use disorder and social determinants of health inequity cannot pull those apart, and they all need to be addressed in unison. And we need to address the social determinants of health and equity. Those are the upstream things that are affecting not just syphilis, but every other health inequity that is affecting American Indian and Alaska Native people. We really need to partner with substance use disorder and other programs that overlap with congenital syphilis. And at the end of the day, we just need more substance use disorder treatment in order to make some really long-lasting change. To approach this also as a syndemic, and first and foremost, decriminalizing substance use in pregnancy. Some quotes are, the #1 problem is the way that we treat substance use in pregnancy. And we need to build more places that people who use substances can go, especially when they're pregnant and when it's criminalized. And we need to all come together in order to make these really important policy changes. And last slide was around building connections and support for pregnant people. One of our colleagues said, when I was pregnant, I didn't go in for all of my prenatal care appointments. I was just pregnant and having a baby. So really like putting ourselves in that mindset and trying to do everything for the person who is just pregnant and having a baby, how to communicate all of the needs that that baby has to the parents and the pregnant person, by having women's circles, by having men's circles that teaches people about what a healthy pregnancy is, and to have resources to all pregnancy needs, not just screening for syphilis, not just prenatal appointments, but eating right, setting up a birth plan, all of that. And then also in this space, building connections and support is around incentives. And Brandy, I see your comment, and like those are the policy changes that are needed in order to to address congenital syphilis, because so many people with congenital syphilis are also dealing with substance use disorder. And then lastly, I just wanted to put it in there, incentives. And I have heard people talk about incentives in various different ways. And that, you know, people will be expecting money to make healthcare appointments, or that they're coming in for the wrong reason, or some other comment. What I would say is clinicians get bonuses all the time based on things they do or don't do within the clinic. This is no different. This is no different when considering all of the structural determinants of health and equity that have made it so difficult for some people to access health. And like I said before, if we're talking about equity, sometimes we need to give some people a little bit more so that they can achieve the same thing. And that is what incentives are doing. They are showing within the Indian health system to get more people in to get screened and treated, 70% of whom are not impaneled and don't have a primary care provider. So I can't say enough about the need for public health to come together and to say that incentives are needed in places, and in the syphilis response is one of those places. So Rebecca, again, we're getting to the end here. Do you have anything to add regarding the Congenital Syphilis Task Force?
No, I'll just give reflections at the end.
Okay, great. Okay, we have one more question. So what are some of the key takeaways from the Congenital Syphilis Task Force? Okay. Right. Fooled you once, not again. Yes, all of the above and more. There's a lot that's needed. Next slide. I'll let you go ahead, Rebecca.
Perfect. I just wanted to add a couple of reflections from the local health department side. Well, local health department and participant. So while the activities shared today focus specifically on American Indian Alaska Native communities, they do not speak only to those communities. And so the whole person syndemic focused care coordinated with the community that's being served is something that benefits all communities and all local health departments. I'm sure everyone on this call, everyone that works in public health hears time and time again that services must be offered outside of the clinic walls. And this was certainly identified in these activities of the summit and the task force. And so speaking to the local health departments that I work with who may be on this call or that I'm taking out of this conversation, but I think also applies to probably any provider, we must remember that the communities we serve go everywhere. And that everywhere might not include health departments or primary care providers. And so we must as well go where the people we are serving are. That's my main reflection.
Thanks, Rebecca. And I'm going to put in the chat a link to something that the Indian Health Services Heroin, Opioid, and Pain Efforts Committee funded to do, and that is family care plans, which is adapted version of plans of safe care. It was really putting family first. And, you know, to Brandy's point, knowing in your state what the difference between notifying versus reporting to Child Protective Services is, what happens in each instance, and then moving to rules and regulations more like Oregon, more like Minnesota, that have put policies in place to really support the pregnant person and encourage the pregnant person to come into care. Because when we look at the missed opportunity CDC slide, we see the missed opportunities of maybe they're screened, but they never come back. Maybe they were never screened at all. And that's because so many pregnant people are not coming into care with substance use disorder because it's not because they don't care about their baby. It's because they don't want to be incarcerated. They don't want to be put in tribal jail, state jail. They don't want their babies taken away from them, their other children taken away from them. So really like putting a lot of thought into what that means. And I think, you know, my last reflection is that family care plans and rethinking what policies we need to support pregnant people and their infants and their families is really, again, about putting the people at the center of this response and how important that is. Like so often we develop responses, you know, based on groups of individuals coming together to make, you know, best policy recommendations and the person's experience who might have syphilis is often not accounted for in those conversations. And so really making an effort to put that person back at the center of the response at the local health jurisdiction level, at the state level, at the federal level, and at the Indian health system level as well is so important.
Fantastic. That was tremendous information. Thank you both for your leadership in this space. We are down to the last few minutes. And so I would love if there's something from the questions and answers, Rick, Rebecca, Jessica, is there anything you wanted to pull out from the Q&As that were kind of coming through in the background?
I actually had a question that I would like to pose, but it's going to be putting him on the spot. So Rick, I have a question for you, which is from the IHS perspective. What do you think was the most important thing that you all heard? Not that you necessarily learned, because I'm sure you were aware of most of these things, but what's something that was really significant that you heard in either the task force or the summits?
Yeah, you're putting me on the spot, but you know, I think significant theme that I heard was that people are seeing this as an urgent need for a full, comprehensive public health response that includes, at its core, American Indian, Alaska Native communities, people who work in sexual health, people who can pass policies, people who provide direct care, and people who are looking for planning, evaluation, all those things. So basically, the joy I got from that was building from the ground up a response to this.
Fantastic. Jessica, anything from the questions that you saw roll through that you wanted to follow up on?
I was talking the whole time. I apologize. So I'm just.
No, it's hard to read the questions while they're going. I should put Rebecca on the spot or Rick on the spot for that.
I do have a question for Cody. I just wanted, and I see that Cody had a question and Rebecca, you responded, but Cody, you used the word consultation. And I just wanted to make sure that people understood that that's a very specific word in Indian country, and consultation is a very purposeful government to government conversation between federal government and elected tribal officials. So you might throw a word around like consultation, but it means something very specific with tribal programs. So we did not conduct consultation. We consulted with people, but we didn't conduct capital consultation that the U.S. federal government does with tribal governments. Just clear the air there.
That's a great clarification and something I've learned since working in this space. I did not know how that word was used differently before. Really helpful.
Cool.
Anything else, Rebecca, you want to highlight?
I was just going to answer Roger's question, and that was whether or not incentives have been tried to bring in contacts and partners. And I can't speak to the American Indian Alaska Native IHS structure, but it's certainly been tried in local health departments and has been proven successful, but not enough jurisdictions are doing it. And there's certainly not enough like sharing on impact that an individual local health department has experienced or an individual state health department has experienced so that other people know about it. So if anyone on this call has used incentives to bring in contacts and partners, reach out to me because I would love to get your story shared out.
And we will have her contact information for you very shortly. I saw a question asking if there were reports or summaries from the task force or convenings that are they publicly available?
They are forthcoming. They will be publicly available, and we will blast out to all the places. So hopefully everyone on this call will have plenty of information about where they can read them, see them. Hopefully there will be more sharings as well.
Wonderful. There were really rich learnings from this work and things we can all take back to our communities that we work and serve in. So I think with that, we're going to pull up the deck again, Damon, and go through our last couple slides and let people go on time. Just a reminder that the final will be finishing our summer on September 10th. This is going to be a really exciting webinar as well, talking about the future forward and what are the emerging trends. And we hope to hear from a lot of our federal partners that have been working on the task force. This should be a really exciting webinar. So please plan to be with us for that one. Also, you can scan this QR code. We'll also put the link in the chat for you to get access to all of our slide decks from prior webinars. We'll be posting the recordings of these in the near future, and some other resources that might be helpful for you in the syphilis space, because there's a ton of resources out there, and sometimes it's strangely hard to find things when you want to put your fingers on them. So fantastic resources out there in the community we want you to know about. And here is the contact information that I promised. So Rebecca would love to learn more about incentives and how you've used incentives. So there's her email address. Jessica's in there as well with the Raven Collective. As always, if you have questions for us at OADP, we've got this address, sti@hhs.gov. It could even be you just need help with something, or you need help with connections, or you're having trouble accessing things. Sometimes what we do best is make those connections for people. So please feel free to reach out to us and let us try to help you do the amazing work that you're doing. Also, as I mentioned before, there is the bicillin, widely available now at 2.4 million units. There's also lentisilin, which is very inexpensive if you don't have access to 340B pricing, and extensilin, which both of those drugs are available right now. In addition to bicillin, but 2.4 million units is widely available. If you're not able to access it, the CDC wants to know. So please email them at stdshortages@cdc.gov. They have not gotten any complaints of this in the last month. So it sounds like people are not having trouble, but we want to know if they are, because sometimes we don't always hear when we want to. Fantastic. Any final remarks from Rick or Rebecca or Jessica to send people forth?
Go forth and act in community.
We're here as a resource, and we certainly couldn't do the work without all of our partners at the local level and our federal partners. So please reach out to us, and we'll make sure we do the same for you folks.
All right. Thank you guys so much. Thank you for your expertise you brought to the webinar today, and all of you out there for joining us. Hope you have a fantastic day, and we will see you on September 10th.